Welcome back, everyone. I am pleased to introduce Dr. Donald Chi. Dr. Chi is a professor in the Lloyd and K. Chapman Endowed Chair of Oral Health at the University of Washington School of Dentistry in Seattle, Washington, and serves as Associate Chair for Research in the Department of Health Systems and Population Health in the School of Public Health. He's dual board certified in pediatric dentistry and dental public health. Dr. Chi's research focuses on understanding and addressing oral health inequities. He teaches public health to dental students and pediatric dentistry residents and has been a staff pediatric dentist at the Odessa Brown Children's Clinic in Seattle since 2009. A warm welcome to Dr. Chi, who will present oral health considerations for individuals with CF. Welcome, Dr. Chi.
Great, thank you so much, Jim, and thank you for the Institute for inviting me to speak today about oral health. So 4 objectives today that I'd like to achieve. First, I'd like to review what's known about oral health of individuals with cystic fibrosis. I'd like to outline the factors that are known to lead to poor oral health, specifically in CF. I also want to give you all a sneak peek or a preview of the CF dental research that's happening at the University of Washington in Seattle. And then lastly, I want to provide some clinical tips on optimizing oral health over the CF life course. So first, I want to start off with my story about how I ended up in the CF world. This actually started probably about 10 years ago, and I happened to be waiting for a medical visit. I actually don't have, before this, I had no ties to cystic fibrosis. I don't have any family members with cystic fibrosis. This was just a serendipitous discovery or kind of occurrence that happened while I was waiting for a checkup. And while I was waiting for my physician to call me in, I happened to pick up a pulmonary journal that happened to be laying around, and so I flipped it open and actually landed on a CF related article. And as I was reading it, this had nothing to do with oral health. As I was reading the article, I started thinking back to my dental training, both during dental school and during residency training when I was learning to become a pediatric dentist, about what I had learned about cystic fibrosis. And the one thing that stuck in my mind, and this was consistent across the 2 training periods of my life, the thing that stuck out was, well, we learned that people with CF don't get cavities, and they don't get cavities because of antibiotics, and that was it. So I was like, huh, that's really interesting. So I was like, it's been a while since I've been in the classroom. Let's go to the literature to see if this still is the case. And so after my appointment, I went to my office and looked up a few articles to see if this actually was the case. So most of today is going to focus on what we know about children with cystic fibrosis, given my clinical interest in children and teens, and so I'm going to share a little what I know about the literature in this area. So, so consistent with what I had learned, most studies out there continue to perpetuate the idea that individuals with CF just have good oral health, that cavities weren't a problem, that really that they have a pretty clean bill of health. And this, despite the fact that the profile of children with CF would fit the profile of someone who actually would be high risk for cavities. We know that individuals with CF are on high-calorie diets, and if those high-calorie diets contain high amounts or large volumes of carbohydrates or sugars, that's a source of nutrients for the intraoral bacteria that metabolize those sugars and then spit out acids. And it's those acids in the mouth that create holes in the teeth that we know are known as cavities. We also know that medications that individuals with CF may take could lead to dry mouth. On top of this, we know that there are problems with reflux, which introduces stomach acids into the mouth. So not only do we have the bacteria producing acids, but we have extrinsic acids being introduced into the mouth. More recent studies at the time, now they're over 10 years old, had shown that individuals with CF, or actually this was a mouse model, that mice with CF had 20 times the level of intraoral Streptococcus mutans, which is the main bacteria implicated in tooth decay. And then on top of this, there were structural defects that individuals with CF were known to be at higher risk for. Enamel defects are one of these. And enamel defects, enamel is the outer coating, or I'm sorry, the outer part of the tooth. It's the hardest structure in the body, but individuals with CF are known to be born with a predisposition to defects in the enamel that then make it so that the sugars and bacteria can stick to the teeth more easily and lead to tooth decay. So despite this profile, studies continue to perpetuate this idea that individuals with CF were at low risk. Now this is where things started to break down for me, and I started to get very suspicious. And this was where the explanation used, or the explanation presented, was simply that individuals with CF were on chronic antibiotics, and that was the explanation. And really, that's where I started to dig. And this chronic exposure to antibiotics wasn't something that most of these studies had actually studied empirically. These were hypotheses presented usually in the discussion sections of the papers. And so there actually wasn't any strong support for this explanation that antibiotics was in fact the reason why individuals with CF were at lower risk for tooth decay. So this got me thinking, okay, if the explanation is weak, or that there's not support for this widely accepted explanation for this paradigm, maybe it's time to actually question the paradigm, and that's exactly what I did. So I did a systematic review of all the studies looking at tooth decay in both children and teens with cystic fibrosis. And what I found through this qualitative systematic review, in fact, was that children, so younger children with CF, tended to have fewer cavities than individuals without CF, so non-CF controls. But what seemed to happen over time, particularly during early adolescence, is that they would lose this protection. So what was happening is that younger children with CF tended to have lower cavities or lower rates of cavities than controls, but that this tended to come to parity as these individuals got older. Now, this led to a pilot study that we conducted here at Seattle Children's Hospital. And this, at the time, so we enrolled 85 children and teens and young adults, 6 to 20. And at the time, this was actually, and actually probably still is the case, this is the largest prospective study of CF and oral health done since the 1980s in the US. And there have been a few studies outside the US, but again, to show you that not a lot of research has been done in this area. And in fact, what we found confirmed the findings from the systematic review that kids between the ages 6 and 9 with CF had significantly fewer cavities than controls. And where we see this here on the graph is this divide between the blue line and the red line that happens early on between 6 and 9. And then what happens is that between the ages of 10 and 20, these lines start to match, the red and the blue lines start to match, which means that cavity rates actually tend to be not different. Now, what we can see here at the very, very end here at age 19 and 20, and this is really, I think, what helped to motivate the larger study that I'm going to present today, is that you can see that the lines are starting to separate again. You can see there's a little, sorry, and I should have had a bigger image here, but you can see here that the blue lines and the blue line and the red line start to diverge again, and what this shows is that the cavity rates actually start to separate again. So we don't know what happens after age 20, but this pilot study helped to confirm some of the findings that we found from the literature. What we also found based on this literature is that acidic saliva pH is a potentially important risk factor for cavities. So we collected both stimulated and unstimulated saliva from these individuals with CF, and we found that that acidic saliva is a risk factor. What we also found, based on a different data set, is inequities based on income. And so lower income children with CF, so these would be children who are enrolled in Medicaid, they were less likely to utilize dental care than individuals without CF. And so there appeared to be maybe some access to care problems for our lower income children with cystic fibrosis. So here we have, we did a systematic review. We did the pilot study with the 85 individuals with CF. We did some ancillary studies, and then we also looked at Medicaid data. So what this gives us is this starts to paint a picture of what the risk factors for cavities might be for individuals with CF. Now, again, what we found is that there is a salivary component and a bacterial component. So there's something about the saliva being more highly acidic, and there being more bacteria in the mouth that is contributing to cavities. There also are more CF-specific risk factors. So we know that having a lower FEV1, using bronchodilators, and then GERD were also independently associated with tooth decay risk in CF. So these are typically not risk factors that we see in a general population, but these are more CF-specific risk factors. And then we have this third category of risk factors. So not getting dental care. If you do get dental care, not actually getting fluoride during your dental visits, and fluoride typically now is the really sticky stuff that dentists or a hygienist may paint on to the teeth that add that extra protection against cavities. And then, not surprisingly, soda intake as well as sugar-sweetened beverages. So here we have, we're starting to put together a model here where there are some factors that are not specific to CF. So some of these bacterially mediated disease factors, such as the salivary pH, as well as the Streptococcus mutans levels. We know that those are risk factors for all of us when it comes to cavities, as well as these green oral health behaviors. These are also implicated in cavities for all of us. But we also, on top of that, have these risk factors specifically related to CF. So we can see here that we're starting to develop a model for tooth decay in individuals with CF that is going to be really important in not just understanding the pathogenesis of tooth decay in individuals with CF, but more importantly, where is it that we can intervene to actually prevent tooth decay? So what's going on at the UW? So this pilot study, after multiple attempts, we were able to secure a 5-year NIH grant to study these issues. And this is the first CF oral health study funded by the NIH. Again, it's the largest US dental study since actually our study was published just a few years ago. And our plan for this study, we started enrollment in March, just a few months ago. And our goal is to enroll 210 individuals with CF between the ages of 10 and 30. And this is a multi-center study. And so we have a large group of collaborators and partners here at the University of Washington and Seattle Children's Hospital. Margaret Rosenfeld is a multiple PI on this grant. We also have the CF and the dental team at the University of North Carolina, Chapel Hill. And then we're also working with our colleagues at the University of Alabama, Birmingham. So multi-site study, complex. I think the study itself is actually pretty straightforward, but when it comes to multi-center studies, these can get pretty complex in terms of ensuring that that the protocols we use, that the methods we use are identical across all the sites. We have 3 aims with this NIH study. So the first is actually related directly to our pilot work. And this really is aimed at trying to identify the modifiable or risk factors that can be changed when it comes to cavities and gingivitis. And so part of the risk factor assessment is that we're doing longitudinal surveys. So over the course of the 5 years, the 210 individuals that will enroll at baseline, our goal is to actually have them back 3 times total. So we'll be able to do some longitudinal surveys, and that's just enough time to see changes in tooth decay. Tooth decay takes about 6 to 9 months to appear. So you can have a patient who comes in or an individual that comes in with no tooth decay, and let's say those risk factors are really high. Anywhere from 6 to 9 months is when you can start to see tooth decay in the mouth. So given the study design, this should allow us with these longitudinal surveys and increments or increases in tooth decay that we expect to see in some individuals, we should actually be able to identify risk factors longitudinally through our surveys. And we also we're also planning to do interviews to identify strategies to improve behaviors. So let's say, we know that sugar sweetened beverages are problematic. That's kind of one level of knowledge. But the second level of knowledge is, okay, so how do we actually change this? If an individual is consuming 6 sodas a day, and our goal is to get them to maybe consume 2 sodas a day, how is it that we get that change? And part of this is information we hope to glean from the qualitative portion of our first aim. The second aim is to actually look at links between dental diseases and pulmonary health. So it's this idea that what happens in the mouth likely affects what happens in the lungs. And surprisingly, there's not a whole lot of work out there in CF as well as non-CF linking dental diseases and pulmonary health. I think this is an example where, in dentistry, we talk about these oral systemic links a lot. And there's not necessarily a lot of empirical evidence of a causal link. And so we're going to try to hopefully get a little closer to understanding, okay, what happens in the mouth? Does it affect pulmonary health in individuals with CF? And then the third aim is, if it does, what are the mechanisms that link dental disease and respiratory disease? And our hypothesis in the third aim is to conduct oral and lung microbiome analyses. So we'll be collecting a whole bunch of different samples, saliva, supragingival plaque, subgingival plaque, as well as sputum samples to try to understand the microbiological links. And as you can imagine, this is again an important area when it comes not just to the basic science understanding of what is it that links the mouth and the lungs, but again, when it comes to disease prevention and trying to help individuals with CF have better respiratory health, perhaps one way to do that is to actually influence what's happening in the mouth. So I'm going to transition a little bit to the adult world now, and this is really, I think, one of the exciting offshoots of the work that we've been doing, mostly with children as well as young adults, is adults with CF, and we know that the same problems that children have and teens have follow us into adulthood. So we did one study with actually our transplant colleagues here at the University of Washington to look at lung transplant time. And this is a study that was led by one of my PhD students, Ala Al-Khatib. And what she found is looking at waitlist times for lung transplant, as well as dental disease rates. There was no difference between individuals with CF compared to other adults with other types of respiratory conditions, COPD, end stage, lung disease, and other types of respiratory non-CF diseases. And what this study actually, I think the importance of this study is that, again, back to that paradigm that I talked about at the very beginning, that individuals with CF don't get dental disease. If that in fact was the case, we probably would have seen some sort of difference in terms of dental disease rates, in terms of the adults with CF that we looked at, as well as or compared to those without CF. But more importantly, this idea of pulmonary waitlist time is this idea that if an individual with CF, if they come in and they don't have a whole lot of dental disease or no dental disease, their waitlist time actually should be shorter, right? This idea that they don't have to go in and get all of their dental work done. And anecdotally, this is something that we hear a lot about in clinical scenarios where an individual with CF, they're all ready to get their lung transplant, and then they have to go get a whole bunch of dental work done before they can get their lung transplant. But again, the fact that we didn't find any difference in waitlist time or dental disease, again, leads me to think that this paradigm that we've been teaching, dental students and dentists, probably for the last 40 or 50 years, may need to be updated. So Ala actually, got so interested in cystic fibrosis, she actually worked on the saliva study as the master's student. She wanted to expand the work and look at gum disease in individuals with CF in adults. So what she did as part of her dissertation is that she so far has enrolled 32 adults with CF between the ages of 22 and 63, and this is actually through the adult CF clinic. at the University of Washington Medical Center. And so far, what she's found is that about 30% of individuals in her study presented with moderate gum disease or periodontitis. And no one so far has presented with severe gum disease. And I just wanted to put this model up here and share this model with you to show all the different hypotheses that she's testing. And so she's going to be working on this. And actually, she's defended. She has her PhD now, and most of this work is actually has been submitted for publication. So stay tuned. There's a lot of interesting work that's going to be coming out of Ala's dissertation. In terms of future research, lots of work in progress areas, again, offshoots of our pilot work with children, as well as new work that we hope to propose here in the future. One of the big things, back to the idea that chronic antibiotics, are the reason why individuals with CF don't have cavities. We're sitting on a mound of medication data. And one of the studies that we hope to do with the child data that we have is to look at the role of CF medications in cavities, to look at the frequency, duration of intake, route of intake, other types of features of medications like adherence, to look at this. And this role of medications is so complicated. I think it's we spent a lot of time actually collecting pretty fine-tuned, very, very detailed data on medications. And the fact that we have cavity data as well, and there was lots of variation among the kids with in terms of both cavities as well as medication intake. We're hoping to clarify the role of medications and cavity risk in children and teens with CF. The other, I think, interesting arm is what are the protective mechanisms present for children with CF? So contrary to this general paradigm that all individuals with CF are at low risk for tooth decay and other oral diseases, our data actually do seem to support this idea that children with CF do seem to be protected. And I think that that's a really important question as to why. What is it about children with CF that seems to protect them from getting cavities? Is it behavioral? One of the possible hypotheses is that the caretakers of children with CF just may be on top of health behaviors like diet, as well as toothbrushing, getting their children to the dentist. It could be behavioral, but it also could be biological. There could be different microbiology happening in the lungs, which might impact the type of medications and antibiotics they take, which again can protect children. And there is some evidence, again, with children in the medical literature about microbiological shifts that happen during early adolescence between children and teens with cystic fibrosis. And if there is a microbiological shift happening in the lungs that then prompts different types of antibiotics to take place, that could also influence the microflora of the mouth. And so all sorts of really interesting hypotheses to test with these younger children with CF. And we have a couple of proposals right now where we're trying to get some of this child CF work funded. And then the other piece, and this is actually related to our current NIH-funded study. I have a graduate student, Jenna Castillo, who is a PhD in sociology. She's in the PhD program in sociology at the UW. She's interested in medical advice given by CF care team members, and what she's proposed is looking at the CF care team. So this would be at children's hospitals, to look at what type of oral health related advice that CF care team members are giving children and families. And so this would be dietitians, as well as pulmonologists, nurse, and social workers. And it's this idea that that down the road, if we're going to do interventions aimed at improving the oral health of individuals with CF care team members are going to be critical members of any kind of oral health intervention. And it's going to be really important to make sure that the dental folks, as well as the non-dental health folks, that we're all on the same page when it comes to the type of oral health related advice that we give. So an example of this might be, a child with CF, a CF care team has concerns about the child not gaining weight. So the priority, understandably, is to get that child to put some weight on. And so one of the things that might happen is that the child might be encouraged to just eat whatever it takes, high calorie foods, sodas, which can help to put pounds on, just basically whatever it takes to gain weight. Now, from a dentistry standpoint, what that then creates is a scenario where those sugars from all those foods can create oral health problems. And in the olden days, when life expectancy was 20, 21 years of age, maybe it didn't matter as much that the teeth had to hold up during the course of one's life. But we know now that CF life expectancy has reached or has surpassed 50 in most places, and so it becomes even more important that people are able to keep their teeth during the entire course of life, and really it becomes an oral health related quality of life issue. It becomes a general quality of life issue of being able to retain your teeth, being able to enjoy being able to chew your foods and not having pain in your teeth because of cavities or gum disease. So this idea that I think there's going to be a paradigm shift, I think it's starting to happen now with some of the studies that we've done, but we hope in the future to be able to do interventions that can help shift this paradigm even further. And a big part of this, like I said, is going to involve CF care team members. So really interesting, important work that we're really super excited about. So some oral health tips. Okay, so we have all this research mumbo jumbo, and I'm used to meeting with CF support groups, meeting with teen groups and stuff, individuals with CF, and they're always interested in kind of, okay, what do I do now? The research is what it is, and Donald, maybe in 20 years you'll come up with an intervention strategy that can help to prevent cavities. What do we do in the meantime? And I think this is a valid, important question. So it's pretty easy, and I think for me, I tend to go back to the behaviors. And again, I'm a pediatric dentist. My background is in public health, but really most of my research focuses on behaviors and how it is that we can help individuals engage in optimal behaviors. And then also, how is it that we can shape or reshape the social context in which these behaviors occur? So when I think about behaviors in terms of dentistry, taking all the research findings that we've been able to amass over the years, and then putting on my clinician hat, I think the first important thing is making sure that dental visits are happening regularly, and this can be every 6 months, it can be every 12 months, but that these dental visits are happening regularly. I think what this gives dentists an opportunity to do is to provide some oral health monitoring and what we call anticipatory guidance. So this is where we can take a look at the mouth, ask questions about risk factors, and actually provide patients with really tailored advice on ideally what they could be doing to lower their tooth decay risk or their gum disease risk. And so I think that this is really important. Now, I know during COVID, it's been tough. A lot of dental offices, haven't been open regularly with all the new PPE requirements and distancing requirements, testing requirements in a lot of places. Dental visits can be really hard to get. And there's also just a lot of nervousness about the dental office being a source of COVID infection. Surprisingly, and this may be because dentistry is one of those areas where PPE, the personal protective equipment, we've had pretty good PPE standards in place ever since the HIV/AIDS epidemic started, where gloves obviously are mandatory. We've always used masks. We're now wearing hats and other types of protective equipment. So the dental environment, despite the fact that it's probably thought to be an environment, ripe for COVID infection. Actually, there's not a whole lot of evidence out there that the dental office, that there's a lot of COVID infection happening in dental offices that actually comply with PPE and clinical standards of infection control. So important to get to the dentist every 6 to 12 months and make sure you're going to a dentist where the dentist and the staff is abiding by, again, by where they're using masks, where they're vaccinated. Again, these things are important. Preventive care is also really important. So it's not just the advice that you get from the dentist. It's the preventive care, the direct preventive care. And this can come in the form of sealants. And so sealants are plastic coatings that we put on the grooves of your back teeth, on your molars. And so what those grooves do is that those grooves are natural. We all have grooves on our teeth. Some of us have groovier teeth than others. And these grooves actually they serve as a physical source where plaque and food can get stuck in them. And that's really how the decay process starts, on the grooves of the teeth. So sealants help to block them out. And these happen, sealants are placed in children, but they can also be placed in adults who are at high risk. And so sealants are really important in terms of preventing tooth decay on the chewing surfaces of the teeth. Fluoride is another type of preventive care that dentists routinely provide. And as I mentioned before, fluoride is that sticky stuff that's painted on the teeth. Some dentists may apply a foam or a gel in a tray that kind of sits on your teeth for 3 or 4 minutes. But whatever the mode, the fluoride is important. And this type of fluoride, biochemically, it's similar to the type of fluoride you get from toothpaste as well as fluoridated water. But the big difference is that the fluoride you get from dentists is kind of a super strength, a high concentration of fluoride. And this is why it's done under the supervision of a dentist or a hygienist. And so it's a really high dose of fluoride that you get just during the time that you visit the dentist. And so fluoride exposure, really it's a matter of getting fluoride exposure in different ways. And the fluoride that you get at the dentist's office is important in that way. I think the other thing that's really important is that having a dentist, having what's called a dental home, or a place to go to for regular dental care, is important because it's a source of emergency care. So let's say you fracture a tooth, or you get a toothache, on the weekend. Having a place that you can go to for dental care also means that when there's an emergency, you have a place to go to, which means that you can stay out of emergency rooms. You can just have a source of care if you need, and so that's really important. In terms of other behaviors, I think reducing added sugars is another really important behavior. And we know that sugar intake actually is probably the single most important behavior implicated in tooth decay. And so if an individual actually stopped eating sugar, their risk for tooth decay probably would plummet almost close to zero. It's the added sugars in things like sugar sweetened beverages, candies, the refined sugars that we eat, that really are problematic. And there's been a shift. I think historically, we would think about cutting sugar from your diet as cutting candies and gummies out of your diet. And those things do cause tooth decay. But what's really happened, I think, over the past maybe 10 or 15 years, especially with children, but adults as well, is that sugar exposure is coming mostly in the form of sugar sweetened beverages. So sodas, juices like Tang, Kool-Aid, those are really problematic in terms of really elevating one's risk for tooth decay. So trying to find ways of reducing added sugar intake is going to be important. And then back to this issue of fluoride. Again, fluoride is important. It comes in different modalities. So kind of on an everyday, multiple times a day, basis, water fluoridation is important. So the amount of fluoride in the water, which is 0.7 to 1.2 parts per million, it's a tiny amount of fluoride, but study after study we know shows that water fluoridation is really super important in terms of protecting the teeth from getting cavities. At the next level then is toothpaste. So toothpaste has a slightly higher concentration of fluoride in it. And toothpaste is something that we use typically 2 times a day. So toothpaste is that extra kind of protection that we can get a couple times a day. And so it kind of ups the amount of fluoride. And so that, again, is safe and important. Now, for individuals who are at increased risk for tooth decay, and this is really where I think goes back to that first point of talking to your dentist about your tooth decay risk. There are other fluorides that you can add into your routine in addition to fluoride toothpaste. These include rinses, so fluoride rinses like ACT. You can get these at the grocery store, but there also are prescription strength fluoride rinses that are available. And then supplements. So these are the things that, for those of you who grew up during a time where fluoride supplements were handed out routinely. We still have them. So these are either chewable tablets that that you get from the pharmacy, or they can be drops that you put in your water. And so this is again another source of fluoride. And in terms of the recommendations for supplements, supplements are really recommended for individuals who live in areas where the water is not fluoridated. So if you're in a non-fluoridated area, we do recommend supplements, either in the form of chewable tablets or drops that you can put in your water. And then dentists are also a source of fluoride. So you can get the fluoride varnish or the gels or foams from your dentist during routine checkups. And with that, I wanted to leave more time for discussion and any questions that might be out there. So again, I want to thank you. I want to thank CFRI for this invitation, and for our funders, Sunstar, as well as the CF Foundation and NIH. And so thank you so much for your attention, and I'm happy to take any questions or discussion points.
Dr. Chi, thank you very, very much. And you did span the childhood to adult issue with dental health. And I know this is an issue that impacts many people. So thank you for sharing your time and expertise. How exciting about the NIH study. That's just such a huge marker. So the questions are rolling in. The ones I can start off with: how do you find out if your water is fluoridated where you live?
Yeah, that is a wonderful question. So a lot of this data is actually publicly available. So you can, if you're on a public water source, you can actually Google it. So find out where your water is coming from. And so I think there are search engines. So here in Washington, we have the Washington State Department of Health maintains a pretty accurate, up-to-date water district thing where you can put your address in, and it'll spit out information, on whether your particular source of water is fluoridated. Now, for those of you who are not on a public water source or may have like well water, there are sources that you can turn to. Again, a lot of state departments of health, they may have testing available where you can send in samples to get your water tested. So that's one possibility. And so I think that it's important, again, if you're on public water, public sources of water, it's easy to find out if you're on fluoridated water. And if not, it's really important to get tested. And well water, we find, the literature shows well water can range from 0 to a lot of fluoride. So the well water really can vary. And so it's really important to know. And the reason why that's important to know is that if your well water contains too much fluoride, again, it's all about getting the right amount, right? And my whole thing about fluoride is regardless of your source of water here in the U.S., you're not going to get the type of fluorosis that you might get in other countries. Places outside the U.S., some of the water sources actually have a type that have concentrations of fluoride that can lead to tooth defects and other problems, skeletal problems. We don't have that problem here in the US, but you can get more than you need. And there are filters that are available that will actually filter fluoride out. So my whole thing is, get the right amount, not too much, not too little, get the right amount. And that's why it's important to know.
Goldilocks of dental health.
That's right.
So next question: do certain CF medications have lesser known side effects affecting oral health, like albuterol?
Yeah, that's a really great question about medication. So what we know, and this is actually information that we know from kind of the general literature, medications are problematic for two particular reasons. One, this is related to the sugar piece, is that a lot of times medications don't taste good. So there will be things that are put into the medication to make it taste better. So for kids, that may be a sugar carrier. And so, kid doesn't like, something that tastes bitter, you add some syrup into it. And so then it tastes, like cherry, Kool-Aid, and it's sweet. So that can cause problems from again, a sugar standpoint, especially if that individual is getting a lot of sugar exposure from their diet as well, and then also not brushing and not getting the fluoride that they need. So I think that's the first area of concern when it comes to medications. The second area really is related to the dry mouth. So a lot of medications can actually lead to physical dry mouth. They can actually affect the salivary glands, where you actually where you stop producing saliva, or your salivary production goes down really low. And saliva is one of those things that is actually really important. It helps to buffer the acids in the mouth, but it also helps to actually protect the teeth. It actually has enzymes, and there are things in saliva that will actually physically protect the teeth. And so every time you have, every time you eat something sugary, that's going to damage the teeth. The saliva actually helps to neutralize some of that damage that happens. And so if you introduce a medication that leads to alterations in saliva, that can be really problematic. So really, it's those two things. So you want to check, regardless of kind of what medications you're on. You want to look at the medication list to see, again, is there sugar being added to it, or is there sugar part of it, and is there maybe an alternative, maybe a sugar-free carrier that can be used for medications? And then secondly, is it causing dry mouth? And dry mouth is one of those things I think most people, they know if you ask about it. It's kind of hard to kind of measure. So if you don't, if someone asks you about dry mouth and you're like, well, I don't know if I have dry mouth, oftentimes the person's fine. Their mouth is perfectly fine. But again, there are inventories out there where you can take, a 10-item inventory to see if you do have, or if you're at risk for xerostomia, and that would be a source of tooth decay risk.
Somebody's curious about why the study is cut off at 30 years old.
Yeah, that's a really great question. Again, these are the tiny little things that, when you put a grant together, they just kind of seem arbitrary, but there was a lot of conversation about when you start, when you cut off. And the reason for that is actually age 30 is when we start to see gum disease, periodontitis, in adults. So individuals under age 30, rarely do we see periodontal disease. So periodontal disease is actually different from gingivitis. Gingivitis is where basically, if you stop brushing for a few days, or maybe if you stop flossing for a few days, you might notice that your gums bleed. That's gingivitis. It's reversible if you start brushing again, if you start flossing again. The gingivitis, it's caused by bacteria, basically, that sit on your teeth and your gums. And so, the bleeding is a sign of inflammation. Gingivitis is reversible. Periodontal disease is not. So periodontal disease is actually, it's similar in that there are bacteria involved. And so bacteria kind of collect and accumulate. But what happens is that the bacteria, kind of a layman's way of understanding gum disease, is that the bacteria in the mouth essentially melt the jawbone in the mouth. And so, as you can imagine, if that jawbone melts over time, this is why gum disease leads to tooth loss over time. That bone, the jawbone, is what keeps the teeth anchored in the jaw. And so if you have what's called the alveolar bone shrinking over time or melting over time because of the bacteria, that's when you get pockets. So you may know when you go to the dentist, when they probe you with that really uncomfortable sharp thing, and they shout out a whole bunch of numbers, 2s, 3s, 6s. 2s and 3s are good. If you're in the 2 and 3 realm, that's good. 4s, you're starting to kind of see, bone loss. 5s, 6s, 7s, 8s, that's when you actually are starting to see severe bone loss. And so you don't actually start seeing periodontal disease until age 30. And we just, based on our pilot data, we just didn't have enough data to demonstrate a need to look at periodontal disease in CF, but this doesn't mean that it's not important. And actually, that's probably another important area. And this is really where Allah's work, I think, is really phenomenally important. We have some more knowledge about children, but I mean, it's virtually, I mean, there's so much we don't know about adults with CF and oral health. So lots of opportunities.
And we're glad you're pursuing this.
Me too.
So somebody said, post-transplant, I developed extreme sensitivities to cold on one side of my teeth. My dentist thinks it could be lack of fluoride. Any thoughts?
Interesting. Just one side. That's interesting. You know, it could be, I don't know if on that one side, maybe there were some restorations present, you know, and it could be that that those restorations might be differentially affected again by different changes that happen post-transplant. Again, going back to the medication issue, if you have medications that lead to dry mouth, especially with post-transplant medications, you can have gingival overgrowth. So that's where the gingiva or the gums swell up and actually can cover the teeth. So you can have some local changes that happen. And so, yeah, I think that that is possible. And yeah, that's, yeah.
Is the study available to those who are willing to travel to one of the study centers mentioned?
Yes. Actually, I think I think actually, well, I think the individuals they have to be patients of record at the 3 sites, and so if you've kind of fall within that age range and you're a patient of record, then yeah, that would be totally possible. And the reason for that is it does involve multiple visits, and so what we try to do with our study visits for our NIH study is to combine them with clinical visits. So that way, you know, you're not having to come back again just for the study. But yeah, you know, one of the things is that there's always, you know, we're always looking for partners and potential collaborators. So if there is a CF care site near where you are, please mention, you know, share, you know, your interest, and we're always looking for partner sites. And so, so this could be a way for us to actually start a new collaboration. And as I mentioned, you know, I could probably come up with 12 important studies, and so all of these studies would require sites. So we're always looking for partners.
And is the study listed on clinicaltrials.gov?
It should be. Well, actually, no, this is not a clinical trial, so no, it will not be in
Okay.
clinical trials. But if you go to my website, there should be kind of an explanation for the study. Yep, and it should be, and it's actually on the NIH website. So the NIH website has a collection of all the studies that are funded now.
Perfect. And we will share more information about this.
Great.
Let's see. This is from a CF researcher. Do individuals with CF have a different oral microbiome?
That's a great question, and the simple answer is we don't know. So really, this study will be one of the first to really systematically look at this issue. We won't have non-CF controls. So again, the question, you know, oftentimes comes, okay, what is the CF microbiome compared to the non-CF microbiome of the mouth? And I think for us, this is one of those really important kind of study design questions that we really wanted to that we really, you know, struggled with at first. Is really, are we comparing CF to non-CF, or are we trying to find pockets of high risk within CF? And I think it really is the latter that we landed on. I think there are some really important basic, maybe microbiological basic science questions related to CF versus non-CF. But I think when it comes to kind of the dentist in me and the interventionist in me, you know, we know that CF, you know, generally speaking, you know, that there are going to be pockets or subgroups within CF that are higher risk. And so those are really the subgroups we really want to target, especially knowing that that individuals with CF, you know, have medical vulnerabilities, you know, that they're categorically at greater risk for infection. And so our idea is that, okay, so given this medical complexity and vulnerability, what can we do to identify those individuals who are in greatest need of interventions?
And we are only have a few minutes left, if you don't mind just going over a couple. And then everybody whose questions we don't get to, I'm thinking we're going to come back for a podcast.
Great, yeah, happy to.
So we had a lot of people who commented because of medications they had taken through childhood, they have the discoloration of the teeth, which is a quality of life issue. And so they want to know, do you have any advice about this?
Yeah, absolutely. I imagine, you know, so tetracycline, you know, if you were young and your teeth were developing and you took tetracyclines, yeah, your teeth are probably gray and discolored, and that's something that can't be scratched off. You know, anything extrinsic can be scratched off, but tetracycline staining is intrinsic. One of the things that you can do is see your dentist about getting veneers. Now, again, they're not cheap. Veneers are you know, they're very expensive. But oftentimes, you know, you can get 6 veneers, kind of canine to canine. You don't have to do all your teeth, but you can do kind of the canine to canine veneers to cover that. And veneers will cover that. You can also do full coverage crowns. But yeah, medications can lead to that, and unfortunately, we do know more now where we try to not prescribe those medications, knowing that causes dental problems.
And as a public health person, you just must hate how little coverage there is for dental services.
Yeah, especially for adults. I mean, the adult. I mean, this is especially for adults who may be eligible for Medicaid. The Medicaid adult dental coverage is really spotty. It kind of depends on what state you live in, and then with Medicare, it's similar. There's even less coverage for older adults. Children are covered pretty well, and so we do have some good coverage in terms of Medicaid and children. The problem with Medicaid with children is that the reimbursement rates oftentimes aren't very high, and so dentists won't participate. So it's hard to find a provider, or it can be hard to find a provider. So yeah, lots of kind of health policy problems that the folks in this room are probably familiar with that are kind of rampant in dentistry.
And somebody actually asked if you know whether in countries where these services are covered through a national healthcare system, is there a different rate of cavities? And typically the CF, but general population.
That's a really good question. I think that countries that tend to have universal, coverage in terms of dentistry, and actually it's not necessarily, if a country has universal healthcare, they don't necessarily always have dental as part of that. So that's the other piece. But if a country that has universal healthcare that covers universal dental, oftentimes those countries are just kind of health focused. And so we can't necessarily say that it was the universal coverage that leads to better dental health, but they're just better positioned to have a more healthy population. So yes, so the answer is yes. Now, is it related to the universal coverage? That we don't know.
I'm going to ask one last one, even though we're over, because it's a quick
Sure.
answer.
Sure.
Do you recommend using water picks? And if so, do you suggest any additives such as bleach?
No bleach. I would not add bleach to your water pick, but water picks are good because often, so flossing, and you should still floss. Floss catches everything in between the teeth. Water picks can kind of clean out pockets underneath where you floss, and can kind of clean debris out that floss or toothbrushes can't get out. So yeah, so I think water picks are great, and actually there is some good research out there to show that water picks work, but they should not be done in lieu of brushing and flossing. You should still do all three, but yes, and don't add bleach to water picks. Yeah, don't add bleach.
And should people be doing this before or after treatments? After?
That doesn't matter. I think it's fine. Yeah, after or before is just fine.
Well, I have to end this now, and I know we have questions. And what I didn't share before was that Stacy Ravelis, who works for CFRI, she was planning a podcast on CF and dental health and found through an article Dr. Chi. So we connected to talk about this podcast, but it was such an engaging discussion and there was so much to share that we were immediately, no, you must come to the conference. So now we're going to follow up and we will do a post-conference podcast with Dr. Chi if he agrees, and we'll keep a record of all these questions and make sure that they are all addressed, and hopefully if your schedule permits, we'll do this.
I'd love to do it anytime, Siri.
Thank you so much for sharing your time and your expertise with us. We are really, really grateful to you. And for everybody who stayed with us, we hope you learned a great deal. I'm sure you did. I did. And so this will conclude this session, and then we will meet again in about, I think, 10 minutes or so with an amazing panel on the impact of CF upon the siblings. So you won't want to miss that, and I will see everybody at the next session. Dr. Chi, thank you again.
Thanks so much, Siri. Bye-bye.
Bye-bye.